You talked to Amrita about restricting carfilzomib to higher risk patients. How do you define high-risk disease?
Well, some of it's easy, right? We have high-risk cytogenetics, high-risk gene expression profiling, RISS staging, so that's all easy. But there are other patients who you're surprised if you do their RISS staging, they don't fit 3, but you know they have bad disease. Like, they have huge tumor burden, they have lytic lesions, they look sick when they come in. So I think clinically high risk is also important to consider. And again, younger patients I tend to think of as also high risk, just because obviously if you're 30 and you have myeloma, you're very different than someone who's 70 with myeloma as well.
Some people would push back on this and say, if you're going to treat everybody with the same drugs anyway, why bother even measuring it? What changes in your thinking if you find somebody's got high-risk genetics?
I think this gets at 2 issues, which is there's the baseline risk and then there's the kinetic risk, which is especially in resource poor.
Very fancy talk. Kinetic risk, what is that?
Well, I think if you're in, for example, resource-poor countries where you don't have access to the appropriate fish testing, which should be CD138 selected or plasma cell-specific sig fish, but you could argue that what's more important than a short PFS on induction or failure to respond? So I think that's another element of clinical risk. But I think, again, outside of clinical trial, you can start with a regimen, VRD, and if you don't have the response that you would like, you can either switch to K, give more cycles, as Ed was alluding to. So we're not pinned down to one thing.
Any other thoughts on that, Tom?
Yeah, so I think for the majority of people, I do start them on RVD as the initial therapy. And sometimes we don't have the cytogenetic tests back by the time we've already started their therapy. And then it comes back and they're high risk. And so then what do you do at that point in time? And I would, if somebody had a 17p deletion, I would actually at that time switch them to carfilzomib, lenalidomide and dexamethasone. And it also affects what I do in the transplant eligible. They'll get a transplant post-transplant. So post-transplant, I tend to be very aggressive post-transplant with maintenance-based therapy when they're high risk.
Yeah, me too. Yeah.
So I think that's how
becoming a trend, I think, to mop up after the transplant as opposed to before.
I think one of the caveats or one of the things associated with high risk is not just the ability to achieve a CR, but it's the ability to maintain that CR. So, I'll push back a little bit and say we don't switch to carfilzomib for people that have 17p if they're responding nicely to RVD, but we do use RVD-based consolidation and maintenance, and we've shown pretty good survival for those patients. It doesn't cure or give the kinds of remissions you get in non-17p, but it can be very effective.
If maybe Ed, I'll ask you this question. If your patient obtains a complete remission after induction therapy, so you've given them 5 cycles of RVD and there's no evidence of disease, do you still transplant them?
Yeah, I do. I think that so far, if anything, the patients who have the best responses are the patients who do the best with a high-dose melphalan and stem cell transplant. Until we're certain that we have an initial therapy that is curative, that really destroys every last myeloma cell, then I'm just assuming that whatever's left is somewhat resistant to the therapies that the patients already received. And in every study, it seems like adding a dose of high-dose melphalan will improve duration of response and maybe survival.
Does anybody disagree with that? Is anybody acting differently?
I think in some circumstances I disagree with that. And in fact, I think that is one of the most important discussions with a patient. They've achieved a CR, a stringent CR, and now we're testing, I think we'll talk about it a little later on, MRD status. And pre-transplant, if
minimal residual disease.
Minimal residual disease. If we check it and they're MRD negative at the pre-transplant point, then it goes to a longer discussion with the patient. Because there's no survival difference between upfront transplant and delayed transplant. That we're going to collect now, but we're going to do the transplant down the road, and we're going to follow your MRD status. Now that is off the cuff. There's no trial that has done that. But for some patients, they say, no, I want to do it now, and I say, perfect, let's do it now and let's get it over with. And others that say, you know what, I'll wait, and we'll see how we do at this MRD negativity.
California versus rough East Coast people.
But if I could disagree with one thing, if you look at the trial you're alluding to, the early versus delayed transplant after RVD, 20% of people were not able to get to transplant, so I think that's an important discussion to have with them too. And whether that was disease progression, right, other comorbidities,
All right, Amrita, let's move on here. So Amrita, would you ever go in the opposite direction and do 2 transplants? You did the large stamina trial, and we heard from the Europeans recently on their version of no single, double consolidation. Summarize quickly for us where we're at with that.
So of course we have 2 huge trials that show 2 different results, but they really are different trials. The European trial had cyborg induction, first of all, which I think is a key
That's
point.
cyclophosphamide, bortezomib, dexamethasone.
And they did show a benefit to tandem transplant in especially high-risk cytogenetic population, which is what sort of generated a lot of buzz, is tandem coming back. But in contrast, the stamina trial, first of all, over 50% of the patients had RVD.
Most of our viewers might not know what the stamina trial is, so why don't you explain quickly what it was?
So the stamina trial was trying to answer the question, what's the best thing to do after your autologous transplant to improve PFS? Is that tandem transplant? Is it just stay on Len maintenance? Or is it RVD consolidation and then Len maintenance?
And what did you show?
That Len maintenance was equivalent in terms of PFS to doing either a tandem or to doing RVD consolidation.
A lot of us were surprised by that result. We had in our heads that consolidation was good, and maybe for some patients, even today, a tandem might be helpful. Were you surprised by the result?
I was surprised too, and I think Ed, the co-chair on this trial, probably was equally surprised. I think.
I knew that I was going to get you, but were you surprised, Ed?
Well, we designed the study because we were hopeful that we could make incremental improvements in the care of patients undergoing stem cell transplant. So we were hopeful that one of these arms would be an incremental benefit. I think, though, the results of the stamina study are really interesting and really make us think about the post-remission therapy and what the best approaches for patients who undergo transplant are. I think comparing the stamina study, which is a United States study, with European studies is very difficult. If you really look into the weeds, you see that it's a different group of patients, really. In the stamina study, these are patients who had already received therapy, and then they went to their transplant, as opposed to in Europe, where the patients start right from the beginning on a clinical trial. And so they're really asking little different questions in a different group of patients.
So let's just cut to the chase. Sagar, do you do tandem transplants?
No.
Tom, do you do tandem transplants? AJ?
No.
I guess you should ask both of us. I'm curious to you.
I mean, my own experience is rarely. Started to use MRD, and if I can't get rid of it, I sometimes consider a second transplant. But have you changed your practice based on stamina or the European study?
The only group of patients that I really think about are patients who have a poor response to initial therapy, then have a nice response and tolerate the first transplant, but it still looks like it can go deeper. And that's the one subset of patients who I think about it, which is, obviously all of these clinical trials, in practice, we don't do one arm versus another arm. In practice, what we do is an adapted strategy based on what's happening with the patient.